So good afternoon, everybody. And today's topics, as Richard mentioned, there will be multi-drug resistance and novel strategy to win, stop fighting. Very strange way to say it, but you will understand this idea perfectly right after this presentation goes to the discussion and the solution of the problem. So team, we already presented our team yesterday, and one more time. It's a pleasure participating at the International TRIZ conference, and as part of TRIZ Biopharma, NOIGEL, Farber Centers for Academic Success, and TRIZ Medicine again. That's our team here, CEO, CSO, CMO of the company. And we have definitely established company here in New York, and we are quite efficient company in synergistic combinations of generic FDA approved drugs and also coming up with the development of novel pharmaceutical compositions. Our gain experience in definitely comes up from research and development in pharmacology, bioengineering, and it's all based at the TRIZ and mathematical modeling. Incorporation, of course, that's involved in this development. Now, little statistics. I did mention yesterday some of those points when we spoke about polymyxin, and this is a little more here. It's a multi-drug resistance. It covers wider type of bacteria beyond the gram negatives that we had it yesterday with polymyxin. It's all involved positives and negatives and so on, all the bacteria that involved in the illness. I did show this yesterday, this type the presentation as well, that what we, unfortunately, expectations are not so great. By 2050, of death rate may come up to 10 million a year worldwide, and current we are experienced already problem with 700,000 a year death rate, and it's going to be overgrow the cancer rates by 2050. And that's how it's important, how a significant problem this situation is. And this is like quick one of the global discussion about 10 million in 2050. They calculated it's like one person could die every 3 seconds. That's how devastated problem could be. This one also we mentioned as well, and that was basically, we spoke about it, what's happening with our defense products like antibiotics. Amount of them of novel medication doesn't come up. They cannot create much more as they used to, and those that we have, they are not functional anymore. So bacteria is oversmart our efforts for now, and that's what we trying to solve this problem. Well, this little cartoon, this picture here about microbiology lab, usually suddenly looking at the slides and we see it's worse than we thought. It's antibiotic resistant bacteria, and it's reading gibberish language, so we have to figure it out. What are we coming for that solution right now? So here we have inheritance of system, artificial organs, medicine environment, and this part I would like you to pay attention more, where we have basically specified this multi-drug resistant inhibitors. We specify this different problems here, antiviral therapies, diagnostic, and our goal to come up with dynamic antibiotics, or dynamic or more functional antibiotic at some point. But with this is it's a future. The currently problem is still there, and we have to look to the current problem and what we can do about it. So, well, again, Dr. Farber has one of the slides. We are looking for any ideas over there. We have to come up with this idea is how to solve the problem. That's we coming up with methods and new paradigms in medical field based on TRIZ and mathematical modeling, and also modern technologies. Those all three are so crucial and very important. You may ask what's happened, why we end up in this, how far we started and how far we came, and how close we came to the situation. Well, what's caused that? First of all, we started using antibiotics. I could use the word like a popcorn, basically, it's true. Because I'm a practicing physician and I see any very common clients, patient shows up in the office and asking, any problems, give me antibiotic. It's like a store, they asking for it, without realizing the fact it's not a popcorn, neither candies, and has a specific need and usefulness for. So the increased use of antibiotics, prescription taken incorrectly. What that means, instead of taking, when we prescribe, patients do not complete the course of therapy. We prescribe for 5 days, 7 days, sometimes somebody needs for 2 weeks or 10 days. And they cutting short, don't complete the therapy, and bacteria become smarter to that treatment. Sold without medical supervision. Prophylactic use for surgical procedure used to be for many years. Recently, they stopped doing that only for very specific needs. So basically, there are some action taken forward for it, but it's not enough because we're already in having that problem. And this is very crucial. There's multiple antibiotic use for viral infection. Classic scenario that I have in my practice and medical field. Most of the time, upper respiratory infection or some infection related to mainly upper respiratory or the we call that URI or cold symptoms. First, usually it starts 80% of the time. It's a viral cause, and giving antibiotic right on the beginning of this cold symptoms, it's wrong, inappropriate. Although a patient insisting, very commonly we still have to explain them. So using multiple antibiotic for viral infection, that's what that stands for. That's another example of what led to this resistance. That's where we at. So how bacteria become smart. So we have a high number of bacteria, number one. Few of them are resistant, very few. Then antibiotics start killing. We give antibiotic to treat the bacteria. Those are who were sensitive, they get killed. But there's a couple of them left, or some amount, which is didn't respond to therapy. And that was happened. And we have some improvement. Patient feels better. And that's when he stops treatment instead of completing for 5 or 7 days was prescribed for. And then this resistant bacteria said, hey, nobody after me, why not to have a good time or having aggressive time, I would rather say. And they grow aggressive part and releasing toxins, virulence factors, and that nature. And beside that, they have, unfortunately, this part, very strong point, they could transfer, they communicate to each other. And they can transfer the information further bacteria, and it's growing exponentially, this problem. Another issues are using, and it's well-known fact, they're using antibiotics in veterinary. Well, practically same antibiotics. 80% of them are same, if within 90%. For animal has same illnesses, disease, or at times they even using as prophylactic. They use just giving it prophylactically for in the livestock, and animals start carrying bacteria, antibiotic resistant bacteria, which is transferred to our human life here. This is just quick, just update to know environmental, microbial, and viral survivalship. So that's the fact when we like to see to show to you how even they survive. They're not just come and go. They stay like a staph aureus can stay 7 days up to a year. Like C. difficile at the Clostridium, one of those which commonly cause diarrhea, It's could harbor for 5 months in Klebsiella, E. coli. So basically, they're not a bad bacteria until they didn't treat it right. And then they become resistant and dangerous for the body. And this is one of the example, great cartoon, I like that. Don't forget to take handful of other complementary antibiotics. That's a common practice we had. Now it's a lot of changes going on in medical field, which is a great thing, but whatever happened, it's happened. Well, modern medicine, we do depend to access antibiotic. We need them. That's what Nobel Prize, 1945, it was after, right by the end of the World War II, Fleming, he warned, actually, he was predicting the fact, he mentioned that the time may come when penicillin can be, it's actually penicillin that's the first was discovered, was brought by anyone in like a shop, like buying any goods. And then there's a danger that ignorant man may easily underdose himself or may expose his microbes to non-lethal quantities, meaning amount of taking the dosages and drug to the drug, and it's make bacteria resistant. And this is just quick, just like introduction, that in 1950, just showing a little statistic, how difference it make having antibiotics was blessing to make people to survive. People were dying, just diagnosed with pneumonia. It was like a lethal diagnosis at that time. From survival of 25%, it went to 80% of survival. So antibiotics are, we need them, but because of being resistant, they become getting useless. Or we afraid we may return to pre-antibiotic era. That was one of the conclusion was made in Tanzania. And in Europe, currently they have 25,000 to 30,000 patients die from multi-drug resistance. And this is a cost, at least 1.5 billion per year. This is one of the options currently. A lot of companies, a lot of funds, a lot of grants, plenty of governmental grants and pharmaceutical, they're working on conquer this problem. And this is different directions: probiotics, immune stimulation, vaccines, even that part. I've shown another graph about the vaccines part as well, and different approaches, but hasn't come up with any great solution yet. So this is the little trend of how was the antibiotics was developed, as I showed to you, exponentially nice. They were coming up with great amount of antibiotics, different classes, functionality, non-toxic or less toxic to the body, and then drastically goes down. It's problem to develop a good one, or not good one, but smart one, I would rather say, smarter than bacteria. An amount what was already created, this they put on the shelf. They don't use them as much anymore as they used to. They're not functional, unfortunately. But what we have a growing factor of vaccine. That means what we're looking forward of how to make our body immune system to resist to this bacterial intervention, or especially those resistant bacteria. So this part, this vaccine development coming up right now. And what we want to discuss about antibiotics right now and how to bring them to the market and revive them. This is just quick. Of course, it's expensive for the countries. It's $1 billion of waste or investment, whatever you could say, for being managing this multi-drug resistant bacteria. And it's growing. Problem is growing due to the fact much more bacteria is getting resistant, and they're much faster, unfortunately, than doctors or medical field can reach them. The moment we create antibiotics, they already, we're still behind, regardless how much of effort was made. TRIZ, smart bacteria can be only conquered by smart and non-traditional method of treatment. And that's what those bugs gonna afraid of, coming TRIZ in medicine. So Ishikawa's diagram, we just put it down. What do we plan to do? Use FDA-approved drugs, that generic drugs again, here to utilize them for our project. We, with minimal side effects, make sure medication we choose or the compositions or have less side effects than they can cause any troubles, and they wouldn't interfere with any antibiotics function as well. And so we mentioned they're going to be injectable form, so that's why it can reach to the target much faster than tablet form, at least for now. Of course, in future, we're looking forward for the tablet forms as well. Well, little cartoon here, preliminary testing shows that it wasn't paid bill. So we come up with preliminary anti-action, TRIZ principles we're going to utilize, and preliminary action. And this is another quick cartoon for preliminary anti-action and preliminary actions, where we called a conference meeting, and that will be a preparation for a meeting, to preliminary meeting, where we will discuss our upcoming meeting. So it's kind of confusing in between, but there's a stronger point behind it I'll show right now. So system, how to operate for pathogenic microorganisms fighting. So we have put it in the past, present, future, and ideal final results. So past, we have microbiome combination, antimicrobial plants extract, and we have a just antimicrobial plant extract. Present, we have a super system microbiome, static antimicrobials. Very strong point about being static, and we will explain to you as well. And what we're looking forward to come up with dynamic, because it's a well-known fact that nature is dynamic. And being in pharmaceutical, in that, especially in the bacterial world, being structure static, it cannot adjust that resistant phenomenon that bacteria creates, not to respond to that static antibiotic. And ideal final results definitely to deal with this pathogenic microorganism and oversee and avoid that pathogenic organism to create our future resistance. This is three structure of functional analytical methods, improving the system as well, where we covered up actually different our developments. We're talking about resistance research. We're talking about resistance research on the bacterial side, which is our biofilm, adhesions, toxin formation, inhibition, and we're also talking about how to make this resistance inhibitors, so they can come up with different targets on the bacterial cells, and that will change, next development here. As you can see, again, we mentioned about optimization, self-assembled drugs, quasi-living alive drug. This is future. That's the ultimate goal. Meanwhile, we're going to work more on the bacterial level and how can we revive existing antibiotics and make them more functional. This is great, was mentioned by Napoleon, very much matching what's going on right now. You must not fight too often with one enemy or the same enemy, or you will teach him all your art of war. So more we target those bacteria, same antibiotic, and it's static, it's getting used to and know how to oversee it, override it. And another thing is, remember if I mentioned to you, win without not fighting. That's the one here by Sun Tzu. To fight and conquer in all your battles is not supreme excellence. Supreme excellence consists in breaking the enemy's resistance without fighting. So how can I break without fighting? So I want to show you, start from the solution here. This is the development cycle of technical system, and this is growth curve of microorganism. Very similar. And this is taking from all this with microbiology, and it shows what bacteria does, how bacteria function actually. So bacteria has a cycle: lag phase, logarithmic growth phase, exponential, then stationary phase, and death. This is normal natural cycle for bacterial world. And known the fact in lag phase, they fighting to survive here, or bacteria fighting with each other to come up to this area so they can prosper and grow. In the lag phase, where they produce all the toxins, defense mechanism called biofilms, virulent factors. Coming to the log phase, bacteria usually is growing, there's no danger. In this phase, they just losing their defense mechanisms, they dropping them out, and they free without any defense or very mild any factors in this log phase. So that's the phase we're going to discuss right now, and very crucial. That's logarithmic growth. Bacteria, in the absence of competition, it does, they dump all these virulence factors and biofilms and toxin formation. And it also may eliminate factors acquired antibiotic resistance. Yes, even that it makes them even not capable to develop resistance to antibacterial that was going to be given to them. So this is the log phase going to be our treatment, our target in the treatment zone. So you could see on this diagram, classic diagram, if you watch this very closely, how this number of bacteria are growing by the same exponential way as it grows, the amount of toxin production and concentration are dropping at the same time when they grow. This is perfect example on X levels here, what we're going to basically discuss further. So what are strategies? It's a well-known fact, as we're just going to repeat again, log phase will decrease bacterial release virulence factor and biofilm formation. Our strategy to fool bacteria by synchronizing them in that right here, this area, our synergistic composition from well-known drugs, if you see here, going to be affecting bacteria to go to the growth phase and make them full bacteria, that there is no any danger. And based on this phenomenon, our generic composition that's becoming a novel composition will be in a synergistic combination, 2-3 different compounds we're going to bring to that level. And this is just explaining the fact in W stage, they're all armed, they're fighting, they want to survive, and then they have a defense mechanism right here without touching that part. In the X stage, in the field of X here, that's where we going to target that area, and that's where the plenty of nutrients and stimulatory factors here on bacteria, and they're losing their defense mechanism, and they're losing their antibiotic resistance as well. Even those bacteria which was resistant to, they're not resistant anymore to those same antibiotics. Ideality, right phase and right time, right phase and at right timing. So bacteria must constantly be growing in the phase X, in the X zone here, and in order to be sensitive to antibiotics. Number two, composition that we come up with has to synchronize or bring the bacteria to that phase. And that's where bacteria are going to lose their toxic influence. And it is desirable that such substance it's going to be made from FDA approved, well-known medications for different purpose. So we are repurposing them for different needs. There's a TRIZ, and an innovative approach to the problem. So new use of available resources transition to the super system from available resources, build an immune system with synergistic properties. Our pharmaceutical composition based on generic drugs, which is approved for other purpose. Okay, that's what we just said. Our composition, instead of killing bacteria, it's not going to do danger. They're not going to feel danger. That's the perfect point here. It's initiate their growth to log phase, and result in bacterial elimination, protection, and virulent abilities and toxic factors. Composition efficient only in synergistic combination. So those substances that we use for this composition, they only doing that particular work, particular efficacy, only in their combination. If we use them separately, individually, they don't work for that purpose. Synergistic combination, efficient enough to use that each of this combination such a small percentage, so we hardly have any toxic reaction or toxicity from those substances. And the reason we're taking a smaller amount, again, because of synergy. So we don't need to take them higher dose. And reformed as a result of our composition, potentiators, as we call them, because of their potential bacterial growth, the bacteria could be quickly killed by losing their defense factors, right? And they could be killed by using their antibiotics. That's what they were resistant prior to it. That's one of the TRIZ example in inventive principle number 13, inversion, or do the opposite, or the other way around. Instead of killing bacteria, we just came up with this great solution. We provide them comfortable zone. We fooling the bacteria, as I mentioned before, and it will decrease their resistance, virulent factors, and defense mechanisms. The other way around, You want a proof? I'll give you proof. Or you want a proof? I'll give you different proof. And here we go. That's a proof. So NOIGEL solution and proof to concept. First of all, we have to find the right target. So NOIGEL identified the most suitable candidates for bacterial growth potentiators, as we call them at times. And we called it NGL025. 550 substances were selected from 38,000 FDA generic drugs. And NOIGEL selected only 3 substances in that composition, which going to do the proper as a growth enhancer or potentiators. So generic drugs, as we said, based on these classes of derivatives, pyrimidine, isoquinoline, and imidazole classes, they do decrease bacterial virulence factors, but so means of getting the comfort bacterial growth. And this composition, NGL025, has minimal or none side effects for host body and does not affect antibiotic activity or doesn't prevent from antibiotic to do the job. This is a proof of concept again. It basically repeats the previous slides. Again, this combination here. Standard approach, that's another thing I would like to mention. Currently, how they trying to treat the problems of multi-drug resistance. They're using 1 antibiotic, 2 antibiotics. It doesn't work, 3 antibiotics. Number 2, then they're taking 2 antibiotics here. Then they're taking 3 antibiotics combinations. At times they take 4 antibiotic combination for same bacteria to concur to deal with this problem. So it's not just 1 antibiotic as it used to back in the years. They have to combine different antibiotics, hoping so it's going to work. It does work at some point, but some point don't. And it's growing this problem more and more. Our MDR approach, we take antibiotic, 1, and we put our potentiators, put them together, and it's going to work. And meaning bacteria, not the antibiotic going to work, bacteria becomes sensitive to the antibiotic that was resistant to. So we developed this composition. We make MDR, multi-drug bacteria, less harmful. We make MDR bacteria sensitive to current and future antibiotic that's going to come up to the market as well. that's, as we mentioned, prevent future resistance and eliminate and decrease resistant strain selection in future, as I mentioned right now. Here's another proof, an example from, it's called in vitro studies based on Petri dishes. You could see here we used polymyxin, or that great medication last resort, as we mentioned yesterday, amikacin, and this is the Petri without, there's nothing, it just antibiotics and multi-drug resistant Acinetobacter bacteria right here. Here we have same bacteria, same antibiotics, but now we're adding to it our potentiator. And you could see a growth retardation, meaning destruction of bacteria, started on day 6 of growth. We call second passage, both of them on day 6. And this, as you can see, on day 9, we just overseeing on day 9. We're not going to see the previous slide, I mean, the one without, because it's obvious, nothing going to happen. Day 9 or 10 or 20. But here we see only with our potentiator how those resistant bacteria start getting destroyed. And here you see on day 12, they disappearing for good. So here we see Pseudomonas aeruginosa, a different bacteria, multi-drug resistant, and it has similar studies without potentiators and with potentiator. And you could see a difference how this area of destruction going on of the bacteria, those who were resistant. But now we oversee on day 6, second passage destruction growing, this disc are increasing, getting bigger, and that's the result. Day 9, Pseudomonas aeruginosa was resistant, Pseudomonas aeruginosa were destroyed. Same antibiotic, it was resistant prior to. And this little graph here, as we can see, zone of growth retardation, where that's a medium with our potentiators, it goes exponentially, destruction of, growth retarded destruction of bacteria here. And here, without our potentiators, no difference it makes. This is our data here, great data about, we use different potentiators, different concentrations, ABC here, with different concentration of those substances. And based on that, we came up with a great solutions. There's two different compositions and concentration of those substances, where you see great response on those Pseudomonas aeruginosa resistant bacteria. Here we have number of that previous slide was about adhesion, how we decrease the adhesion index, and there did a great job on the adhesion index. One of the defense mechanisms is number of microbial cells after potentiator and the combinations, and it shows how it effectively was destroyed and worked, especially this combination with these concentrations worked much better than previous concentration. And that's the way research goes, and we choosing certain composition and different concentration that works the best. This is table just show without NGL, the zone of growth retardation, meaning destruction of the bacteria, not much changes, and see how that exponentially growth of retardation with our potentiator based on the different passages, meaning different days. Day 2, day 6, day 9, day 12. It's just destruction here. Without potentiator, regardless of the day, no changes on bacterial growth retardation. This is, you see, if you see this ATC, the different, it's also Pseudomonas aeruginosa, but different type of it. And this is different type of, and it works on different type of resistant bacteria. This one show how the colony stimulation timing need to grow the colony. If you see control medium, there's no potentiator, And with potentiator, the amount of bacteria grows much faster. We need them timing spent to grow them way faster than without potentiator. Why we need this? Because the faster we bring them to the log phase, the faster antibiotics, and the faster they lose their defense mechanism or resistance, and the faster antibiotic can affect them. And this is different types of Pseudomonas aeruginosus, and they all responded similarly on our potentiator effect. And this one shows colonies, which is growing within 24 hours. And with potentiator, as you can see, we have a great efficacy how to bring amount of bacteria to bring to that log phase to make them less resistant and prepared to be destroyed, kind of. That's what we know. Bacteria just get food, going to the growth phase, losing their defense mechanism and getting destroyed by antibiotics. These are our successful results. Absolutely. And that's what basically, where we can see microorganisms that we targeted, and we have a great results on those bacteria in vitro studies. These antibiotics we challenged, and this is our ongoing project right now. And as a matter of fact, on mycobacteria tuberculosis, we already have some results. And I just want to bring to your attention one of the, they call the medical world as anecdotal case, meaning one of the few cases they called us because they had no choices. That's where we have 42 years old gentleman diagnosed with tuberculosis, getting advanced, and you see the haziness right here on the lungs between the ribs. That's the patch infiltrates and the nodules here, some right here, and that's the tuberculosis affecting him quite significantly. So this gentleman was already in the clinic, practically almost a month and a half, treated with second-line drugs therapy and HRZ protocol, streptomycin added. They put in him second-line therapy, as I said, with quinolones, etinamide, etc. And he still clinically was doing terribly with spikes of fever, losing weight, loss of appetite, generalized weakness, and he was not responding on current treatment. So this is what classically we're dealing with TB resistant, multi-drug resistant tuberculosis. And then when we just asked with, of course, with his permission and different formalities, the volunteers, we give him a therapy based on our protocol with our potentiators, which, as I mentioned, they're all existing medications. It just has to be known how to combine them, how to deliver to the intravenously, and in what combination and which therapy. We used same therapy that he used prior to it. We added our potentiators, and he got better on the 15th day, meaning 2 weeks later. Within 2 weeks of therapy, his cough subsided, shortness of breath dramatically improved. His fever that he never stopped, it came up to normal. His symptoms improved, the appetite, his breathing, everything went much better. We repeat chest X-ray, and that's the result. You don't see those fluffy infiltrates. It's cleaning out, destroying the mycobacteria. And a year later, we follow up on him. He looks great. There's no recurrence. So this is one of the examples of just, sorry, that's another slide. We had it before, how we approached the case. One of the volunteers needed help. So in vitro studies, so this is our plan right now. So what we planning to do, definitely it's our ongoing plan. In vitro studies we completed, as I showed you, on petri dishes. IND applications we pre-submitted, planning to pre-submit in the second quarter. And here we have, after approval, we should go for phase 1 and phase 2, so clinical trials. So this is something what we're looking for the clinical trials, because IND could be applied because we have generic drugs, and that will be accepted for that purpose. looking for investment. As you know, it's usually the protocol we work with. Definitely, we're going to apply for the grants, for approvals, IND, as I mentioned to you previously. And we absolutely have publications, multiple publications about this matter. And we have intellectual property behind it. And this is, by the way, just quick, one of our posters we were presented on the, we had in 2000, pre-pandemic, we had been invited to Bio New Jersey. We had a great event there, some posters, and we also participated in the Bio New Jersey pitch competitions for investors. That was a great event there. This is NOIGEL. That's the products we also mentioned yesterday. That what we currently working with. That's the projects we're in. Some of them are, those are repurposing medications plans. This is creating new generations, and this is diagnostic tool right here. Well, this little excursus discussion about TRIZ and application for future drug design. That's what Dr. Farber will involve. And I definitely want to thank you, our great hardworking team, who are really, I would say, cherry pick selected team we have. And just coming together is not enough, as Henry Ford said. It's just beginning. And keeping together, that's the progress. Well, working together, that's what we do right now. It's a success. So that's our team right here. As we mentioned, I want to thank all our team and colleagues who worked with us, been working with us for all these years. It was great results and future opportunity that we have. And thank you very much. And as usual, it's optimistic view for in our medical and pharmaceutical fields. Any questions?
Dr. Klein, you're all set. We don't have any questions for you at this time on the chat box. So thank you very much for your very enlightening presentation on attempts to inhibit bacteria within the system. I have a question for you. Where does bacteria live in your system? Is there any one place in particular?
Good point, but I would say bacteria lives everywhere. We actually, I wouldn't say we're one big bacteria, so we are actually loaded with bacteria. And a bacteria is not a bad bugs, or they are saving lives most of the times for the human nature. The problem is when we getting bombarding them with antibacterials, or they overgrowing, or there's a become our microbiome become, we call that bacterial disbalance, then same bacteria what was just living in our organism, streptococcus or staph, they become are more aggressive because disbalance for different reason. I'm not going to get in that details. And then it becomes dangerous bacteria, and they live everywhere. We have them. It just matter of when they become from friendly to aggressive. When, as I said, this balance in our organism is that due to we got viral infection, immune system goes down for different reason. If someone got cancer or something, or illnesses or diabetes or some other illness can bring to that dysbiome, it's called disbalance in the bacterial balance. So then we're getting those bacteria which has become from aggressive bad bacteria that you mentioned, Richard. So then we start saying, okay, we need to bring this bacteria down. How? With the bat, that's called antibacterials, antibiotics, right? And they calm down and we feel better again. We bring it to the balance. But now we having much more and more, I would say, stronger and more aggressive bacteria in our life in our everyday living, especially in the hospital-based world and with the sicker patients there. And they're spreading out to outpatient, to regular field that we practice. So that's where these bacteria are. But overall, that's what I guess I would cover, that bad bacteria comes from. They're not bad until we start disbalancing in our system, or we start disbalancing them with antibacterials, or they becoming oversmart us. So we still need to balance it out somehow. And that's what my presentation was about, bringing back those same antibiotics, but revive them back to the market so we can utilize them to keep those unleashed bacteria down, to get them to the balance level.
Thank you very much. I appreciate the explanation.